Hi, I'm Dr. Sridhar. This is a screen recording from my Telegram channel, and this colleague has asked about this X-ray. 8-hour-old, 35-week female with severe respiratory distress. Respiratory rate is 80, saturation is 92%, and the baby is on CPAP. So his question is about the choice of antibiotics. So let's see the X-ray first. So it's a rotated film. As you can see, the clavicle is going upward on the right, and that puts the heart shadow more towards the left. So you're seeing more of the right lung, and you don't see much of the left lung due to the rotation. You can see the thymic shadow at the upper part on both sides. We have the air bronchogram prominent on the left. You have the reticulogranularity prominent on both sides, especially as the right lung is seen more on the right. The lung inflation is reasonable. So if you count the rib spaces, so you have 1, 2, 3, 4, 5, 6, 7, 7 to 8 rib spaces, and we can also look at the posterior ribs. So what you are seeing clearly on the front of the screen is actually the posterior ribs, because the anterior ribs stop short. The anterior most part of the cartilage is not seen on the X-ray as it is cartilage, and the ossified bone is in the back. So what you're seeing clearly is the posterior ribs. And the other important thing to look at in any baby that is on respiratory support is a tube. So here we don't see the feeding tube, either because it's not radiopaque marked in their unit, or it's not yet inserted. So make it a habit that any baby with respiratory support, so this baby is probably on a RAM cannula or a high flow device. You can see the nasal cannula, but there is no feeding tube clearly seen. So make sure that any baby on non-invasive respiratory support has a feeding tube in place. Regarding the question of antibiotic choice, obviously it depends on the risk factors, and most of the babies, if the mother has GBS positive or PROM or fever or any concerns, you would go for a broad spectrum cover, and the first line is adequate unless the baby is severely unwell. So first line antibiotic like ampicillin, gentamicin in our unit, or it can be any other choice that you have. In the developing countries where there is multi-drug resistance, you may go for a broader spectrum, but avoid escalating unless there is clear signs of infection. So then he goes on to ask if the mother is intubated. The mother history of GBS is negative, and if the baby is intubated, what antibiotics you would choose. So obviously the severity of the lung condition depends on what the underlying diagnosis is and the severity of the problem. So it doesn't necessarily mean there is a severe infection. For example, if it is RDS in a 35-weeker, which could still be there, you are not going to be escalating antibiotics for the RDS sake. So you would support the baby's respiratory condition, intubation surfactant if needed. If the CRP or the white cell counts are high, I don't generally do procalcitonin in the first 2 to 3 days because it tends to be high and difficult to interpret, even if you use nomograms. CRP gives almost a similar information. So if the infection risk is high, then you would consider escalating the antibiotics. You could use a mother's urine culture or other factors as an indication, or your unit's antibiotic choice. But if the baby is clinically responding well, even if it is pneumonia, first-line antibiotics are adequate unless there is clinical worsening, shock, and other parameters. So the only time you would rush to go for the high spectrum antibiotics like meropenem is when the baby is clinically deteriorating in septic shock-like picture, and you don't have time to wait and escalate depending on the progress of the baby. The repeat of the X-ray doesn't really help unless you think of a complication related to ventilation like air leak or lung collapse. So mostly the repeat X-ray doesn't give you much information on whether the baby is responding to the treatment. It's more the clinical response and the inflammatory marker response. So the key points here: treat the respiratory problem according to the situation. A worsening respiratory condition or need for intubation doesn't necessitate escalation in antibiotics unless you think sepsis is the cause and the baby is worsening rapidly. And try to avoid unnecessary use of the extended spectrum antibiotics because you will end up in encouraging resistance, and in a more premature baby, the risk of dysbiosis and colonizing with ESBL is much higher in such cases. So I hope